welcome back to the Orthopedic Tutor channel. And this series of videos, we will discuss the huge topic regarding compression neuropathy. But first, I would like to dedicate this single video to tell you guys what are the basics science that revolves around compression neuropathy and the rest of the theories regarding the median, radial, and also the ulnar nerve compression neuropathy will be divided or discussed in several videos. So let's get it started. The first thing about compression neuropathy is that you need to know it is actually a nerve problem that is caused by, well, simply put, compression. So there has to be a force that compresses on the nerve long enough and in a huge enough magnitude to cause symptoms in a normal human being. Now, knowing that, we should be able to predict the symptoms that came out, which is firstly, it should affect nerve fibers that gives out the coverage of light touch, pressure, and vibration sensation. And lastly, if the compression is long enough and severe enough, it will present as a disturbance in the pain and temperature. Well, besides all of these, you also need to know that there are several clinical findings that can be found in patients with compression neuropathy, which includes night symptoms, clumsiness of the hand, dropping of object, and also weakness. Night symptoms are frequently correlated with the position that we place our hand in. As you all might know by now that during your sleeping time, you may find that your hand is seldom positioned in a flexed elbow, flexed wrist, and also flexed finger position. And this certain position you cannot control it because it happens during your sleep time, and this positioning will alter the amount of force that is being directed towards the nerve, and therefore some of these compression neuropathy might have night symptoms. And besides that, you need to know that there are basic associated conditions with nerve compression, and that is well put inside this table here. You could see here that compression neuropathy is frequently associated with these various conditions such as systemic, inflammatory, fluid, anatomic, and also mass. And I would sometimes try to remember them using the massive mnemonic, which is M for mass, A for anatomy, and then S for systemic, I for inflammatory, and F for fluid imbalance, with each of it stated clearly here, causing the nerve compression. And these are most likely the same for most types of compression neuropathy, because you can find diabetes associated with various types of nerve compression neuropathy and not just on the median nerve. Now, moving on, we could see that there are several examinations that are usually performed to help us diagnose this condition, and the first would definitely be EMG NCS. For those of you who are not familiar with this term, EMG stands for electromyography and NCS stands for nerve conduction study. So basically, there's this device that allows us to evaluate the muscle function, and it is shown in a sort of like EKG chart. It shows you the spikes and the downs and the highs and the lows of the muscle function there, which allows us to determine whether or not the muscle is still in a healthy state or not. And next would be the NCS, which is a nerve conduction study. This side of examination evaluates more on the nerve function. It measures a lot of things, starting from the latency, the nerve velocity, conduction velocity, and so on. And as you can see here, that as compression neuropathy progresses, it goes from an early stage down to a late stage. Now, at the early stage, you could see that the EMG and CV results are usually normal. And what happens here actually is that the nerve is in an edematous stage, and usually you do not need to operate on this kind of patient. But next, sometimes the patient may progress into a more severe stage, which is the intermediate stage, and the symptoms that they felt may be constant all the time, and the NCV EMG results may show abnormality, even though sometimes the EMG may also show no changes or still normal. And what happens is that the nerve is also in a state of edema, while in the late stage, due to the prolonged compression or the severeness of the compression, the symptoms may be a loss of the sensory and motoric function, along with definite changes on the NCV and EMG. And in the pathology, you can find due to the prolonged compression, prolonged damage, the body tries to repair itself through formation of fibrous tissue, and there might be axonal loss. Well, in this case, usually treatment using surgery will give a less predictable outcome due to the permanent changes that has occurred on the nerve. Well, moving on, you need to know that there are also a Sammis-Weinstein monofilament test, and in this test we use a very fine kind of wire, or it is more like a thread. The wire or thread itself, the filaments, they come in various sizes, from a very small hair-like sizes up to a huge filament size, and you just scrape them over at your skin, and the ability to sense the filament with a size of 2.83 is considered normal. And when you cannot sense the fiber with a size of less than 2.83, then it is not normal. The next examination would be a 2-point discrimination. It's called 2-point discrimination because 2 sharp points are being given onto the skin surface, and you need to measure the distance between these 2 points on those skin. And when you can sense, you have the ability to sense that the point comes from 2 different sharp object, then that is considered positive. So when we are able to differentiate those 2 points with the distance between the 2 point of 6 millimeter, then if you're unable to do that, then it's considered as abnormal, and it is usually a late finding. Now, moving on, there are also a terminology that you need to get yourself familiar with, and that is called the Doublecrush phenomenon. We call it a Doublecrush phenomenon because it's a crushing type of force that goes onto the nerve, and it happens at 2 different sites, or double. So what happens here is that you need to know that the nerve also has what we call as axonal transport. So inside our nerve, all those substances that the nerve produce and used up during their normal metabolism will go all the way back and forth from the nerve cell body down to their axon, and we call that as axonal transport. And because that point of nerve there is a single point of nerve that has been that has subdued severe crush injury, then the whole axonal transport is blocked. It's like a highway that has been that when the car goes on and on from point A to point B and back from point B to point A, and suddenly you have a car accident somewhere in the midway inside the highway, and you can definitely know that all things going from point A to point B is disrupted, and the other way goes too. Any car that goes from point B back to point A is also disrupted. So we call that a Doublecrush phenomenon, because injury to one point of the nerve can cause damage or also abnormality in other points of nerve. I'll show this picture to you so that you can imagine that phenomenon clearly. Take a look here at these certain points. These are the points where the carpal tunnel syndrome happened due to the median nerve compression. And these are the points where the anterior interosseous branch of the median nerve syndrome is happening. And this is where the pronator syndrome, which is one of the compression neuropathy syndrome involving median nerve, happens. As you can see, there's this 1, 2, and 3. This is actually a straight point. This is the point or the highway that I'm talking about. And if you have a compression neuropathy, let's say over at here, the pronator syndrome, then all those metabolic transport that goes from this area here over at the elbow down to the wrist is blocked. And those that goes from the wrist back to the elbow is also blocked. And there is no wonder that when someone presents with pronator syndrome, they have also additional symptoms of carpal tunnel syndrome. And likewise, if you can find a patient with carpal tunnel syndrome, you need to find out whether or not they have these two other syndromes, because these all are considered one highway, and when there's accident somewhere in the point of this highway, you need to examine the whole thing. And moving on, we'll discuss about all of this compression neuropathy in my subsequent videos. Next, all what we need to know is about the distribution, the sensory distribution that goes on the hand region. We need to know this, and this is what I consider very important point, because these are different. Sometimes people read about it and they have different understanding about it, and I would like to clear it up for you. You could see here that the blue ones goes from the median nerve, and the green one is from ulnar nerve, and the orange one comes from radial nerve. Generally, these are the patterns that you can find in a normal human being. I say normal, what I meant is general population, because at the extremes of those general population, there are certain people who have slightly different pattern of innervation, and that is why sometimes the physical examination that you get from your patient may be different. As you can see here, that even sometimes the whole dorsal aspect of the thumb and these two fingers over at the hand region does not come from the radial nerve. Instead, they come from this yellow region here, which is the lateral cutaneous nerve of the forearm, or this is a branch of the musculocutaneous nerve. Sometimes even the whole dorsal aspect region could come from the radial nerve instead of the half of it coming from the ulnar nerve. And this is very important. And the next important point that I would like to point out is that even at the palmar region of the hand, we could see here that the innervation that comes from the palmar branch of the median nerve is situated only at this small area here, while this huge area is innervated by the proper digital or the proper digital branch of the median nerve, this area here. And that is why when we handle or when we found some certain conditions such as the carpal tunnel syndrome, we really need to know or get used to this anatomy, because you are trying to do a good physical examination by looking at this area here. You need to examine this area here to find whether or not there is any disturbances in your carpal tunnel diagnosis. Next, what I would like to show you here is that the whole upper arm is innervated by these nerves too, which comes from the radial nerve, the axillary nerve, and also the musculocutaneous nerve and the ulnar nerve. You need to know that in the forearm region and also high up at the arm region, there are areas that are being innervated by these four nerve, five, including the axillary and the musculocutaneous nerve. But besides that, there are certain nerve that innervates the skin over at the forearm region that comes directly from the brachial plexus, and that would be those that is innervated by the medial cutaneous nerve of the forearm and also the medial cutaneous nerve of the arm, and those come directly from the medial cord of the brachial plexus. You better to get yourself familiarized with this map, so that when you do a physical examination on the patient, you could imagine this map going on and on around their skin, and you know which area to examine, and therefore they will give you a more valid examination result. I guess that would be all for today's introduction video regarding compression neuropathy. Next, on the following videos, I'll give you a quick look and also in-depth look on all those other compression neuropathy syndromes that may occur for the median, radial, and ulnar nerve. Be sure to check out my video for more information regarding this. Thank you for watching, and don't forget to subscribe if you like to watch more videos. See you next time.